The takeaway from this approach and this lens is that we have to stop blaming individuals, focus on root causes, and identify what we can do to both prevent pregnancy and provide effective supports, especially for pregnant and parenting adolescents, because adverse outcomes are not inevitable. These upstream factors are often referred to as social determinants of health. Most of you have heard of this term. However, in my view, they're neither social nor they're determinant. They're really upstream drivers that shape the conditions in which people are born, grow up, work, and live. And they stem from policies and practices that create unequal distributions of resources and powers that lead to inequalities in income, education, healthcare, transportation, and outcomes. The strongest determinants of adolescent and young adult health worldwide, as determined by a special issue that was done in the Lancet journal, are structural factors. So in communities where adolescent birth rates are high, these are the same communities that often have high levels of poverty, more limited employment and educational opportunities, and advancements for young people and their families. So as was mentioned in the introduction, a framework that I find particularly helpful as we think about both risk and protective opportunities, as well as opportunities for an intervention, is the socio-ecological model. This was developed by Yuri Bronfenbrenner. It dates way back before the concept of social determinants of health, back to the late 1970s. And it's really valuable in understanding the complexity of the vast range of influences on development and health outcomes. What was unique about Bronfenbrenner is he emphasized how all areas of development and behavior can be influenced by one another and the whole environment surrounding them. He was actually on the committee that established Head Start. It was one of the first programs as part of the War on Poverty, actually, that really, sorry about that. That really said that children needed a comprehensive program to give them a head start in school. So not just preschool programming, but comprehensive medical assessments, hearing, vision, dental, and then provided also support for parents as well with immunizations and linked to community resources. This socio-ecological framework also considers the complex interplay between multiple levels of the ecosystem, the individual, interpersonal, and the larger macro sociocultural factors. Each component of the system influences one another in complex and multifaceted ways. And as you can see at the bottom of the cycle, it also has influences that cut across time based on family origin and intergenerational contributions. So it explains risk, but it also considers the flip side, the factors that can be a positive force for optimal development. And this model also suggests that in order to promote healthy development and prevent problems, it's necessary to act across multiple levels of the system. And many of you do that in the work that you do, in the advocacy, in the leadership, and the policies that you promote. Many of you know this, but I'm going to go through a few examples that kind of illustrate this in a very concrete way. So factors that contribute to adolescent birth rates include socioeconomic status, access to income and education, lack of knowledge around sexuality and poor sexual and reproductive health communication with parents, clinicians, and ineffective or non-use of modern contraceptions. There's also cultural and peer norms, physical and sexual violence, experiences in foster care place youth at a higher risk, and adolescents who are bisexual and lesbian are more likely to have been pregnant than their heterosexual peers. I think what's really interesting too is we see a complex interplay of context and puberty development. So the timing of puberty takes place in a social cultural context and has changed considerably over the decades. So currently, the age of first menarche, when your onset of puberty in the US for girls, is 12 and a half years. The average age of first sexual intercourse is 17 years, and the average age of the first birth is 30 years. So the point of this is that the time period in which a young person is at graded risk of unintended pregnancies and STIs spans many, many years. And the vast majority of births to adolescents or pregnancies to adolescents are unintended. Some estimates are as low as 50%, and some of the work that I've done and others of my colleagues find it in the high 80s, even 90%. So what you see here is after marriage and first birth, their risk diminishes, but it doesn't completely disappear. The other point I want to make with this graph is, in addition, between the age at first sex marriage and childbearing, this divide has grown tremendously. And what it shows is that adolescents and young adults really need to have access to evidence-based information and the full range of contraceptive options to protect them from unintended pregnancy. And unfortunately, not all have such access. So at the national landscape, the macro level of the Brenner model, here's sort of an idea of what's going on across our country. Only 36 states and the District of Columbia require public schools to even teach sex ed. 39 states and DC require students to receive HIV education. 28 states mandate both sex ed and HIV ed, and only 22 states require that this be medically factual or technically accurate. And the definitions of what medical, factual, and technically accurate are really vary. So this is the national landscape. Further, at the macro level, here's a map of healthcare centers across the US that offer the full range of contraceptive methods. Of the 66 million women of reproductive age living in the United States, more than 19 million are in need of publicly funded contraception. And of those who are in need, 97% of these women live in what we call contraceptive deserts. That is, they lack reasonable access in their county to a health center that offers the full range of contraceptive methods. This is even worse for adolescents. So to address this, we're working to advance policies that promote reproductive rights and justice, and pushing back against restrictions, not just for contraceptive access, but to promote sexual and reproductive education and care for all adolescents. So this is just like the big picture landscape. And I think it's really important to keep this in mind when we're working with our young people and their families, because we don't know their lived experience and the challenges that they face in trying to get access to education and resource and support, so they have equity in their sexual and reproductive health decision making.